All right, next lecture, fetal circulation. Okay, so it's really important to understand how the blood circulates between the mom and the fetus because it's completely different than what you learned in cardio A&P. So in this lecture, we are going to talk about the 3 germ layers that develop into the different body systems. We talked a little bit about those already. We're going to describe the stages of cardiac development, explain the role of the placenta and how fetal blood flow works with the placenta between the mom and the fetus. We're going to talk about the factors that influence transition from fetal blood flow to extrauterine life. We are going to talk about fetal circulation, how it works in the fetus, what's different between adult and fetal circulation, and how different shunts that are located in the fetus change when transition from fetal to extrauterine life occurs. Okay, so I'm not going to play this video, but adult circulation, you guys all know this. Okay, right side of the heart is the low pressure side. Okay, this blood only needs to be pumped into the pulmonary vasculature. It's pumped to the left side. The left side of the heart is the high pressure side because it has to pump blood to the whole body. Okay, so normal circulation. Okay, we're going to do this little review, right? Non-oxygenated blood enters the right atrium. Okay, non or deoxygenated blood, used blood from the body, enters the right atrium from the superior and inferior vena cava. Okay, dumps from the right atrium. Okay, once the right atrium fills, okay, it's going to open the tricuspid valve, drains into the right ventricle. Once that is getting ready to contract, causes the pulmonic valve to open, contracts, goes to the pulmonary artery to the lungs. Okay, over here in the lungs, gas exchange occurs. Okay, blood comes back through the pulmonary veins into the left atrium, goes down to the left ventricle, out the aorta to the body. Okay, quick and easy, right? So now we're going to relearn how this all works from a fetal perspective. Okay, so some just fun facts for you guys to internalize, and you will need to know these because it'll make sense later. During pregnancy, women who are pregnant slightly hyperventilate. Okay, as they are slightly hyperventilating, that normal maternal CO2 is slightly lower, like around 34, instead of 35 to 45. So it might be 33, 34, or 33 to 35. Okay, this is due to an increase in the hormone progesterone. It's just kind of the way the normal human body works. The baby's CO2 might be 40. CO2 always goes from a higher gradient to a lower gradient. So that facilitates that gas exchange between the baby and the mom. It facilitates the CO2 crossing back to the mom. It aids in diffusion. Maternal hyperventilation helps facilitate gas exchange across the placenta. Diffusion occurs across the placenta from the mother to the baby and vice versa. Blood cells do not intermix between the mom and the baby. It's all about diffusion. Okay, we kind of, you can compare the placenta to like a volleyball game. Okay, the placenta is the net. The blood cells are the players on either side. Players can throw things across or through the net, like vitamins, minerals, nutrients, oxygen. Okay, waste products can come across or through the net. Okay, but players do not cross the net. Okay, this is why babies and moms can have different blood types and it doesn't cause an issue. And here is the placenta. Okay, so this is in your textbook. if you have a current textbook, I think it's page 8, figure 1-3. Okay, this just shows that there's no contact between the two blood supplies. They're separated by a thin layer of villus. Okay, the maternal blood and the fetal blood do not mix. Okay, but they do come in contact with each other in these intervillus spaces. Okay, and that's how nutrients and minerals and hormones, immunities, they can pass through and diffuse across from the mom to the baby. Waste, CO2, etc., can go from the baby to the mom. And this all happens in the intervillus spaces by way of the spiral arteries. And this little picture shows you that. Fetal blood's high in waste and CO2. Maternal blood is high in nutrients and oxygen, okay? Eventually, the waste and CO2 are carried back to the maternal vena cava and the maternal circulation, and then it's gotten rid of. After the fetal blood has received O2 and nutrients from the placenta, it collects into progressively larger vessels until it arrives in the umbilical vein and then is delivered to the baby. So here's just another picture, kind of a more simplified picture. Okay, the mom's PO2 is about 95. Okay, so that's normal PO2, right? 90 to 100. By the time that oxygen gets all the way down to the baby, that PaO2 is only about 33. Okay, the baby does not need a high PaO2. Okay, the mom is supplying everything. Okay, the baby's umbilical vein takes what the mom brings back to the baby. So it has highest O2 content in utero, even though it's a vein. It's the highest potential PO2 the baby will have is about 33 because that oxygen is depleted as it gets toward the baby. Blood is taken back from the baby back to the placenta from the baby in one of the two umbilical arteries. Okay, umbilical arteries have a low PO2 and a high CO2. Okay, this is a shift in thought process for what you're used to. And so we have to remember that umbilical arteries are taking stuff back to the mom. Okay, and because they're taking waste and depleted blood back to the mom, it has a low PO2 and a high CO2. If you look at this picture, what goes to the baby is oxygen, water, and electrolytes, nutrients, hormones, antibodies, drugs, and viruses. Okay, all those things can be delivered to the baby across the placenta. From the baby back to the mom, carbon dioxide, water, and urea, waste products, and hormones. Okay, so again, the blood's not intermixing, but these items are all being diffused across the placental barrier. Now we talked about this in our last lecture, the endoderm, the ectoderm, and the mesoderm. Okay, so we're not going to go over them in detail again, but embryonic development. Okay, so during fetal development, we're talking about the development of the heart here and the circulatory system. Okay, so during fetal development, the heart is the first organ to form. By the 3rd week of life, formation of the heart and the circulatory system begins. However, this development might not be normal because this is also when women don't know they're pregnant, and that fetus might be exposed to chemicals, to or not antibiotics, but biological devices, infections, illnesses, anything that could interrupt this development. So we hope it's good, but it isn't always. The heart is fully developed and fully functional by the 8th gestational week. Again, some women don't even know they're pregnant at that point, and it is fully developed and fully functional by the 8th gestational week. Okay, so if you look through these next few slides, okay, folding and fusion process, days 19 to 21. Okay, so the heart starts with these two vessels, it fuses together. We're starting to see the major components. We have two atrium, two ventricles, brachial arch is starting, the aortic arch is starting, septums are being formed. So this is happening in days 19 to 21. Fourth gestational week, we have a dramatic change in the heart. Okay, there's looping, it starts twisting. As the heart tubes merge, three recognizable structures form, okay? The bulbous cordus, the ventricular bulge, and then atrial bulge. So you're starting to see just ever so slightly, like this heart is starting to take its shape. Okay, and I'm just gonna flip through these slides because this is all happening again within 8 weeks of gestation. So stages of fetal heart development. You can look right here. Okay, tons of stuff happens in the first 4 weeks, and then 5 and 6, it's almost completely formed. Those are all the milestones. As the heart continues to evolve, the endocardial cushions form. We're starting to see 4 complete chambers. We're starting to see all of the vessels emerge. Okay, and by 8th gestational week, again, the form structure of the heart will stay that way. So any defects happen by that 8th gestational week. Now, fetal circulation. Okay, so now we've kind of looked at how the heart's developed, and you don't need to know all the milestones of the heart development. It's just cool to kind of review and look over. But fetal circulation takes a different path than adult circulation. Okay, this is because the fetus has different needs. They don't have to get oxygen from the outside world. They can't get oxygen from the outside world by breathing it into their lungs. They get all of their oxygen, all of their nutrients, everything they need from the placenta, which is obviously in the mom. Keeping this in mind, circulation coming from the right side of the heart does not at all need to pass through the lungs. Okay, a little bit of it does to grow the tissue. Okay, so a little bit of blood goes to the lungs for tissue growth and development, but that's it. The rest of it bypasses the lungs. How does it bypass the lungs? Well, that's what we're going to talk about. Those are the hallmarks of fetal circulation. Okay, so this is big picture. Okay, we're going to see this picture multiple times throughout the rest of the lecture. So refer to this, you can print it off. I love how it's color coded. That's why I use this picture. Red obviously is fresh oxygenated blood from the mom. Okay, so the highest amount of oxygen. The mid-level oxygen is anything that's purple, and then the poorest oxygen content is anything that's blue. Okay, and we're going to watch a video on fetal circulation. Hi. Want to make sure it's all set up for you. And here goes.
Today I'm going to talk to you about
I really like her video a lot just because she takes the time, she colors it out. It's like listening to her voice. She's got a cool accent. So often the flow through the fetal heart is classified by two different paths. Not often. You can learn it as one huge circulatory path like she just laid out in her video, and that's fine. I always teach it to students in two separate paths because it seems to be easier for them to learn. So however you want to do it, I will say on exams, I will probably, or at least in the past, have asked for the two separate paths. Okay, so again, here is that big picture. Okay, exchange of gas happens in the placenta. Oxygenated blood is carried through the umbilical vein. Now, when you're talking about fetal circulation, in the umbilicus, there is one vein. Okay, it's red, this red right here, the big fat red one. There are two arteries that wrap around it. Okay, so on an umbilical cord, and we'll look at the baby that we have, our simulator baby has a really cool umbilical cord that you can see it. One vein, two arteries. Okay, that's in the majority of babies that are born. Okay, so that umbilical vein carries oxygenated, see it's pink, oxygenated blood. Okay, it takes it up to the liver. 30 to 50% of that blood bypasses the liver, okay, through the ductus venosus. The ductus venosus is our first shunt in fetal circulation. Okay, so all the blood doesn't go through the liver. 30 to 50% of it goes straight, bypasses the liver. The other 50 to 70% of the blood goes through the liver and then enters the vena cava. So both of them, whether it goes through the ductus venosus or goes into the liver, they both enter the inferior vena cava. From the inferior vena cava, we are into the right atrium. Okay, in the right atrium, we're starting to mix with some, you know, a little bit of deoxygenated blood. Okay, so from the right atrium, there's two different paths it can take. Okay, it can either shoot across this next shunt, which is called the foramen ovale, into the left atrium. Okay, so this is an open flap. Normally this is closed. Normally that's a patent septum, but in fetal circulation, that's an open flap. So part of the blood will pass straight over to the left atrium. A little bit of the blood will go in from the right atrium to the right ventricle, and it'll go out into the pulmonary artery. Okay, that blood that goes into the pulmonary artery, part of it will go to the lungs to feed them, okay, for growth and development. The rest of it will go through the ductus arteriosus straight into the aorta. Okay, so we're going to break down this to from one whole circulatory system into the two paths, just so it's a little bit easier to understand. So the first one we're going to talk about is the inferior vena cava path. Okay, we're going to describe it by these two separate paths. Here's that picture again. Okay, blood enters through the umbilical vein. So here's your umbilical vein. Okay, the red vein right here. It goes through the ductus venosa. Most of it goes through the ductus venosa, which is your first shunt, into the inferior vena cava. It goes into the right atrium, goes across the second shunt to the, which is called the foramen ovale right here, into the left atrium. It dumps into the left ventricle, and it goes out the aorta to the body. Okay, so it either goes up to the brain and feeding up here, or it goes down into the body. Okay, That is the inferior vena cava path. Again, blood from the placenta, oxygen-rich blood, travels through the umbilical vein. Okay, it hits the liver a little bit, goes off to the liver to feed it. The rest of it shoots across the ductus venosa. Okay, that's your first shunt. Okay, into the inferior vena cava. Okay, right atrium across the foraminal valley into the left atrium, dumps into the left ventricle, and then out the aorta. The superior vena cava path, okay, it's coming from up here. Okay, blood comes down into the right atrium, dumps into the right ventricle, okay, goes into the pulmonary artery, 10 to 20%, so just a little bit, goes to the lungs to feed that lung tissue to help it grow and develop. 80 to 90% goes through this ductus arteriosus into the aorta and into normal circulation. Okay, so inferior vena cava path, superior vena cava path. You can put it all together and you have fetal circulation.
Let's go back to 18 days after conception. Looking in the mother's uterus, you can see the embryo surrounded by its growth sac and amnion. Let's take a look inside. Here's a diagram of the embryo
All right, so now I know that is complex and sometimes it's hard to understand that whole fetal circulation thing. But make sure you study it because you have to know and understand that fetal circulation. So now that we have fetal circulation down and how it's different, there are specific things that happen when the baby is born and the cord is clamped that changes that baby from fetal circulation to adult circulation. So the clamping of the cord and the child starting to breathe allows for better oxygenated blood to start flowing through the vascular bed. Blood that would have returned to the placenta, okay, so you clamp the cord. Blood that would normally have returned to the placenta is now forced to perfuse the lower extremities. Okay, it's being forced through higher resistance because the extremities their vessels are still clamped down. Okay, they were just growing and developing. They weren't actively participating in circulation. Okay, being forced through higher resistance causes the arterial blood pressure to rise. When that happens, okay, as the baby starts to breathe or first breaths, oxygen is brought into the lungs. Remember that baby's PO2 in utero is only 33. So as they start breathing, oxygen levels rise, inflation of the lungs and establishment of their functional residual capacity with air, oxygen enriched air, increases PaO2. It causes pulmonary smooth muscle to relax. It decreases pulmonary pressure, which leads to decrease in pulmonary artery, right ventricle, and atrial pressures. So everything's flipped. Okay, the right side of the heart is now becoming the low pressure side, the left side is becoming the high pressure side. Okay, all of this happens in the first few breaths by that baby filling their lungs with oxygen enriched air and the cord being clamped. It's forcing circulation to change, and it's changing dramatically. And we're talking about within the first moments of life. This is why filling the lungs with air is the single most important thing in transition of fetal circulation to adult circulation. This is why you guys are all learning neonatal resuscitation program. Okay, this is why we do NRP. Because for our adults, it's usually a heart issue. For our pediatrics and for sure newborns, if there's a circulatory issue, it's usually stemming from a breathing issue, from a lung issue. Wait, let me go back one slide. Okay. So changes at birth. Okay, what changes when fetal and transitional circulation is occurring? Okay, so there's 3 shunts we talked about when we talked about fetal circulation. Those 3 shunts serve to enhance the efficiency and distribution of blood in the developing fetus. The ductus venosus, okay, connects the umbilical vein and the inferior vena cava, bypassing part of the blood through the liver. Okay, so 50 to 70% of the blood is shunted through the liver, through the ductus venosus, before entering that inferior vena cava. That's the first shunt. Second shunt is the ductus arteriosus. Connects the pulmonary artery to the aorta. Okay, it supplies oxygenated blood to the brain and upper extremities. Okay, and that's 80 to 90% of the blood goes there. 10 to 20% goes to the lungs, just to feed the lungs so it grows and develops. And then the other shunt is the foramina valley. It's in the atrial septum. It's a flap. Okay, it's an opening in the atrial septum between the right and left atria. Kept open because the right side of the heart is high pressure in the fetus. The left side is low pressure. Okay, blood that comes in shunts across from the right atrium to the left atrium, down to the left ventricle, and then again pumped out the aorta. Okay, these all exist in order to give oxygen-rich blood to the baby, but also feed the tissues for growth and development that need to be fed. When the cord is clamped, okay, so when we clamp the umbilical cord, ceasing blood flow from the placenta to the baby, the atrial system is converted from low pressure to high pressure. The venous system is converted from high pressure to low pressure. Okay, so everything flips upside down. Left atrial pressures are now higher than right atrial pressures, and the foramina valley snaps shut. That happens like with the first breath. Okay, the last weeks of gestation bring the development of smooth muscle around the ductus arteriosus, and with the change in pressures and increase in PaO2, the ductus begins to constrict and forms a ligament. It could take up to 4 to 7 days for the ductus arterius to completely close. And in our premature infants, sometimes it doesn't close. Okay, and we will talk about that when we talk about congenital heart defects. Sometimes in our premature infants, we have to give medications to force the ductus arteriosus to constrict and close. Sometimes we have to use surgery to force it to close. Okay, but that's usually just in premature infants. The ductus venosa closes as soon as the cord is cut, and it also becomes a ligament. So respiratory movements may be triggered by several different things. So I said, when we start filling the lungs with oxygen-rich air, the pulmonary vasculature will relax. That aids in the circulatory transition. Okay, so that fetus has been practice breathing since week 18 or so. Okay, so early on. When we clamp the cord, it causes essentially fetal asphyxia. Okay, chemoreceptors in the aorta and carotid arteries detect a decrease in the PaO2, increase in CO2, and the compression of the birthing process combined with that, when the chest re-expands, air enters the lungs and the PaO2 starts to rise. Okay, so all of these things, fetal asphyxia, okay, cutting the cord, decreased PaO2, increased CO2, and then causing a decrease in pH. Recoil of the thorax, okay, so the baby's born squeezes out through the birth canal. Once they get out, their chest re-expands, air is sucked into the lungs because of that compression of the chest, and then recoil of the thorax. And then change in environment. Okay, so temperature change, tactile stimulation, light, sound, all of these things cause the first breaths to occur. We will learn in NRP, there's other things that we can do to stimulate that baby breathing. Handling and manipulation causes the crying reflex. All of these things lead to the baby's lungs being filled with air. When the lungs are filled with air, that helps facilitate our change in fetal to adult circulation. So it's super important part of the process. That baby must overcome resistance and create a -40 to -100 centimeter water pressure to take their first breath and fill their lungs with air. Because remember, their lungs are filled with fluid. Okay, and they're not completely expanded. So they're just practice breathing. So they start taking their first breath. It takes a lot of effort to get that first breath in. Also, surfactant is not functioning until air and surfactant come in contact with one another. There's also some resistance to tissue experienced during the first breath. So it all leads, you know, this first breath and subsequent breaths after all leads to establishment of the functional residual capacity, which increases dramatically in the first 5 minutes of life. This is why we want babies to cry when they're born. Okay, we want them to robustly cry, because the bigger breaths that they're taking, the more fluid they're forcing out of their lungs, the more oxygen is getting into their lungs, the more gas exchange that can start occurring. When that starts and the PaO2 goes up, then circulation falls into the place where it should. The circulatory changes happen, and then everything kind of falls into place. Okay, so here is basically what I just said, okay? We clamp the cord, that's up here, right? So we cease that circulation coming from the placenta and the mom. First breath generates a massive negative inspiratory force, -40 to -100 inspiratory force just to take that first breath for initial lung expansion. Opening the lung creates an increase in pulmonary blood flow, okay? Replaces the umbilical venous return as the source of preload, okay? So, and we're just switching for circulation around. We have our infant's first breath, lungs expand. Pulmonary vascular resistance drops because our PaO2 increases. It causes pulmonary vascular resistance to relax. When that relaxes, adaptive shunts begin to close. Okay, so the ductus venosa closes. Okay, when the pressure in the left side becomes higher than the right side, the foramen ovale snaps shut. Okay, and then our anatomical shunt, which is that ductus arteriosus, usually starts to close right away, fully closed by 7 to 14 days. Okay, that swing in pulmonary vascular resistance from high to low helps facilitate all of the circulatory flow changes. So it's super important. This is why expanding the lungs is the single most important thing in the delivery room. Okay, when you learn NRP the last 5 weeks of the semester, you are going to learn that acceptable methods of simulating breathing in the delivery room are flicking the feet, rubbing the back, drying the infant, suctioning the airway. Okay, we always try this first, warm, dry, stimulate, before we go to positive pressure breathing. Okay, usually this is all it takes. Okay, we need to make them irritated enough that they cry. This is another thing we're gonna hit really hard in NRP, but I want to introduce it to you now so you start learning it. It'll make it a lot easier later. Remember that our PaO2 in utero is about 33. So at 1 minute of age, okay, when that baby and being born in our terms are clamping the cord. Okay, so when we clamp the cord, the baby is born. At 1 minute of age, we expect their SpO2 to be 60 to 65. That's normal. Why is that normal? Because their PaO2 in utero was only about 33. Each minute they are older, or each minute of life, it should go up about 5%. It will take up to 10 minutes for that newborn baby to reach 85 to 95% SpO2. Okay, so it is normal for them to have peripheral cyanosis. Okay, they need to have that transition and the gradual transition. 10, 15 years ago, babies that had a 1 minute saturation of 60 to 65, the physicians wanted us to give 100% oxygen, forcing that baby into transition. Now they've learned over time and through lots of studies that it's better to let the baby do it on their own. We expect them to have peripheral cyanosis, okay, because it takes time for that vasculature to all dilate. One thing that you're going to learn and will hit hard multiple times, but just start learning it now. Always place pulse oximeter on the right hand because that gives you an indication that is called pre-ductal. It gives you an indication of what kind of blood or how oxygenated the blood that is feeding the brain is. If there is a problem with the ductus arteriosus closing, you will see it on the left hand or the lower extremities because that would be a post-ductal oxygen saturation. So we always do put our pulse ox in the right hand of newborn babies. Peripheral cyanosis is normal. Okay, hands and feet, normal for them to be purple. Central cyanosis is not normal. Okay, so this is when you have to get worried. So after birth, okay, baby's out, we've got them breathing, they're going through circulatory transition. Postnatally, their alveoli enlarge, okay, and they keep growing in number. Remember, they're born, with 50 to 80 million alveoli, and they get up to 300 million. Their chest wall configuration slowly changes. Babies are born barrel-chested, they'll eventually even out, and the length and the diameter of the airways grow. And I have one more video for you guys.
All right, in this scene, we're going to talk about fetal circulation. We're going to take a look at what the circulation in the fetus looks like right before it's born. So let's take a look down here. Here we have a simplified view of the circulation inside the baby.
All right, I know that was super corny. But sometimes corny things make you learn stuff. And there used to be, you see this just for fun rap. I used to have a rapping baby video, but they've taken it off of YouTube because of community standard. Not sure what that's all about. So that is the end of this lecture. I have one more I'm gonna record today. Hold on, now you can see my bright shiny face. I have one more I'm gonna record today on maternal history, labor and delivery, and I will see you guys in the next one.